Hello, this is Miss Pritchard, and I'd like to present spinal cord injury. Within a couple notes within this PowerPoint, there are several links. Those links are to YouTube videos, and I have those links listed on a document where this PowerPoint is posted. I also have some discussion questions over certain slides. They will be represented with an owl there, and there is a document with those discussion points, take-home messages, with the where you can find the PowerPoint itself, and also within those slides, another narrator, Howard, will be going over those. Alright, so let's look at a neuroassessment, and we're targeted towards spinal cord injury. So I think it's helpful to do these in groups of muscles. So you think if we'll start with our lower spinal cord intactness initially, so you may start asking them to move their legs. And pretty much if they can move their legs, then the rest of the spinal cord is probably intact. But if they can't move their legs, there's no movement there, then the next thing to do would ask them to spread their fingers. So that would be like a C7, C8. Can they spread their fingers as their movement? And if they can't do that, can they extend their wrist? If not, can they flex their elbows? And lastly, you hope they can shrug their shoulders, because that is a C3, C4, which would be a ventilatory problem if they can't do that. So those are really important to do when, initial assessment, but also after any kind of procedure, any kind of surgery that may affect the spinal column itself. So ongoing wise, I know you know this about movement and strength, resistance and symmetry. You can see the pictures there over on the right, testing for flexion, extension, and also in lower extremities there, and with the feet, the dorsiflexion. And 0 would be no movement, and 5, of course, being normal movement. And again, this would be important when you think about trends. And where's the patient's baseline, and is anything changing from that baseline? All right, so that was a bit of motor. So let's look at sensory. It's helpful if the patient's eyes are closed. If their eyes are open many times and they're watching you do this, they may think they can actually feel it, but they're just thinking they can because they can see you do it. So please have their eyes closed. And again, begin with their feet. That would be the lower spinal cord first. And usually if they can, with spinal cord, if they can see, they can feel in those dermatomes, they can usually feel all the way up. So what we want is to use light touch, might be a Q-tip, a little bit of pain, might be a pin or maybe a broken Q-tip. For vibration, you can use a tuning fork. There is a nice sensory and motor assessment there link if you want to try that. And you can see that dermatome there, our picture there on the right hand side. You can see where the sacral there is in the feet, lumbar, legs, cervical or thoracic more in the trunk, and then our cervical in our fingers, hands, and goes up into shoulders. And those dermatomes pretty much match the motor also. So sensory and motor, very similar dermatomes. So when you want a quick focused assessment for sensory and motor, usually start with lumbar down in 3, 4, and 5, and that would be the top of the foot and the calf. The next one, T10 is our umbilicus, T4 is the nipple line, C7 and 8 are finger, and then C3 and C4. So when we think about a quick reference here as to where they are, it's helpful to know that T10, T4, and C7, C8. When we divide between paraplegia and quadriplegia, usually quadriplegia we consider like the cervical all the way through T1, and then paraplegia through thoracic, or T2 and below. For diagnosing and assessing, we use this Asia chart, and this is usually used by PTs, and this is very helpful for planning goals and for making realistic rehabilitation plans. It's helpful to work with them to know what goals are in place and what's realistic for the patient to accomplish either in the hospital or in rehab. And again, the level of injury is the lowest neurological segment with intact motor and sensory function. So in other words, if we said that someone was a T10, so everything from T10 and above would be functioning normally. They would be a paraplegia in that they wouldn't have hips, legs, or feet movement if they were like a T10. Alright, so with mobility, let's look at their levels. In C1 to C4, power wheelchair, and we consider them very dependent. With that power wheelchair, they may be able to use a device where they can sip and puff to be able to operate the device, and there's like a straw kind of apparatus that they're able to blow on to operate it, and definitely a sling lift, and they need help with all their ADLs. In C5 and 6, they've got some biceps and some wrist extension. So they still need a power wheelchair, but they can use a joystick to transfer. Excuse me, they can use a joystick for movement of that wheelchair. And these two need help with ADLs and with transfers. Moving on with C7 and 8, they now have triceps. So they're actually to use a lightweight manual wheelchair. They can usually self-transfer with a slide board. They can do intermittent catheterization, but many times they need help with bowel care. And then T1 through 9, more independent, can even load their wheelchair into their car. T10, T12, they're more mobile with long leg braces, but really they're supporting themselves with, like, his braces or canes there. They have significant balance issues. All right, let's look at the stabilization and immobilization in the acute stage. So we'll use collars, braces, and surgery. Over on the right, we'll see something called the Gardner-Wells tongs, and this is specifically for cervical spine reduction and stabilization. Don't see this as much anymore. You're more likely to see a halo vest, but your book does go over this. So these tongs actually screw right into the skull, right in through the dura, so you have to be very careful of infection. And with care of those weights, the weights are actually what are keeping the vertebrae in line. So you don't want to move the weights. You don't ever want to pick up the weights, because if you take away the pressure, you run the risk of that vertebrae moving. So it is very challenging to give people basic care, ADL, and help with skin integrity issues when they're in this position. Alright, so as I mentioned before, more than likely people are now having surgery for stabilization and to release any kind of cord compression. So with surgery, they're going to remove bone fragments, they're going to remove the hematomas and any kind of penetrating objects. You can see there in the bottom left before that procedure, and then the spinal cord is very much compressed, and then after procedure there's more room for that spinal column. So they do decompression laminectomy. They can also do a spinal fusion. They can use wiring or rods to hold the vertebrae together, and I've got a few slides on that. So the whole goal of the surgery is to stabilize the spine and decompress the cord. Right. So for cervical stabilization, I mentioned this halo vest, and it is fixed skeletal traction, and they will align the vertebrae either with or without surgery, and you don't have to be in bed for several weeks like you would with a Gardner-Wells tongs, so you're much more mobile. But you can see those pins go right into the skull, and it holds that external fixator in place, so you make sure that your vertebrae is stable. And it's worn 8 to 12 weeks, and there's just no driving with that. If you can imagine trying to drive a car and look over your shoulder to see any kind of oncoming traffic, or how to merge there when you can't turn your head. I have a picture of a wrench there, which is important. So if you have to do CPR and get the person out of here, you can use that wrench to undo the device. It is really uncomfortable, and we'll talk a little bit about the care and the pin care on the next slide. You're looking for signs and symptoms of infection with that pin site care. Of course, you'll only use one Q-tip per site, and we use things like Neosporin on it. Some, depending upon the facilities, some use half-strength peroxide, some just use normal saline, some use like Zeroform to put around the pins. The pins should not be loose at all. They shouldn't migrate, because if you consider those pins moving and are loose, that means that that vertebrae is no longer stable. The care-wise, you usually wear your clothes over it. They'll give you a couple liners, so you can put new liners in, to be laundered and clean. But it is it is a difficult time with in that type of traction. Surgical treatment for thoracic or lumbar injury. Here they will use internal fixation. So these are like Harrington rods that go in and go right along the spine, and that stabilizes the spine. Reasons for that: better alignment, stability, and earlier rehab. They may do a spinal fusion, where they may take a bone chip, many times from the iliac crest, to use to help stabilize the spine. And you're looking at really steel and metal rods that are implanted, and they stay in. It's not something that's going to be removed. They can do this anteriorly or posteriorly. So nursing focus here, we're looking at log rolling them. Any kind of change in motor and sensation, so it's very important to have a baseline, and then really monitor for any changes. Because if there is a change in motor and sensation, that could be that there's more swelling than was expected. It's possible that the apparatus has slipped of some kind. So if they lose any kind of function, any kind of mobility, it's an emergency, and the surgeons need to be notified. Of course, you're looking at pain control and tissue integrity issues. And I got a picture of that bone flap on the lower left-hand side that they may use to stabilize the vertebrae. Right. This TLSO, thoracic lumbar sacral orthosis, and this is what's used after that thoracic surgery. So if you can imagine, you've had those rods put in. There needs to be time for those rods to heal, to settle in, for the bones to heal. And So initially the rods don't have enough strength to hold the vertebrae intact, so they really need to use their orthosis for getting out of bed. So they would put this orthosis on before they get out of bed. It's real important, because if they were to fall, then chances are they could really do more damage to that initial surgery. All right, more little issues with mobility, tissue integrity, severe pressure ulcers. I know working up on the burn and plastics unit that a lot of the plastics have to do with folks with spinal cord injuries who don't move, are unable, or they choose not to move themselves often, and they have these severe pressure ulcers that go down to the bone, and they really can't feel them, but they are very much an infection risk, and they're very difficult to heal. So nutrition is an issue. Those rotating beds are a good idea, and be alert to pressure points, and then use of slide boards to help people with mobility. And there's a good slide board link as far as how to help someone use that. With upper motor neuron injuries, we'll have a lot of contractures. So there'd be braces, splints, range of motion, things to help with the spasticity. Many times muscle relaxants and antispasmodics can be really helpful. Tizanidine, dantrolene, those are muscle relaxants. You don't want to stop them quickly. They can be helpful. Baclofen can be taken PO and intrathecally. That would be a pump that's kind of implanted in their stomach. It goes right into the spinal cord, delivers medication, helps with the spasticity, and they can, right through the abdomen, they can access the pump to refill it with medication. So that's helpful. Again, you don't want to stop baclofen quickly. It can cause seizures. Diazepam can also very much help with spasms, but you have to worry some about some tolerance there. The sensory perception, they can't feel if things being pinched or it's not in a good alignment, so you have to be really careful with wheelchairs when they can't feel or move their extremities. A couple of devices that may help with ADLs, especially designed. This is something that is specific to spinal cord injuries, and it has to do with thermoregulation, and it's poikilothermia, poi meaning variable, and they take on the temperature of the environment. So if the environment's cold and chilly, then they become cold. They have a loss of the ability of their blood vessels to dilate and constrict. So the blood vessels can't dilate and release heat from extremities, nor can it constrict when it gets cold. They also don't have an ability to shiver. So being mindful of their environment is helpful. And because of that, you might not see a temperature elevation with infection. With the hyperthermia, below the level of the injury, they are not able to sweat. So they can't release the heat there. So this is kind of, as again, real specific to spinal cord injury. Okay, we've looked at thermoregulation and that poikilothermia. So now let's look at elimination and our urinary tract system. So I want you to do another thought exercise here. So if you would, close your eyes and think about what you had to drink today. And maybe your bladder's a little full. Maybe you kind of have to go, but you can't go right now. And you feel that fullness, and you feel that little sphincter contract. So you're waiting. Okay, so now let's have a break. and you're in a safe place to go. Feel that fullness. Let that sphincter go, and you can feel the relief. That fullness disappears. So my take-home message here as you open your eyes is that the voiding is really complex. There's a whole lot of things that must go on for us to govern our urinary system. So let's look at it more specifically with upper motor and lower motor neurons. Many times upper motor neurons, when we have cervical and high thoracic injury, that causes spasticity of the bowel and the bladder. There's this reflex arc that's intact, and you get a spastic bladder, which means that anytime there's urine in there, the bladder gets excited and you get sudden voiding. So it gets a little distended and it contracts, but it doesn't empty completely. So sometimes there's some trigger techniques that you can do to help. And these trigger techniques kind of tell that sacral area, those sacral nerves, that's like S1 and S2, that you need to void. So actually you can kind of stroke the thigh, or even touching a little bit or pinching the area above the groin. That can stimulate to void. Another thing, some people, you can do some consistent toileting every 2 hours, every 3 to 4 at night, and then of course there's catheterization. With the lower motor neurons, it's kind of the opposite. That's where it's flaccid bowel and flaccid bladder. So there's no reflex arc there, and the bladder can become overfilled. And if it does become overfilled, it harms the bladder. It also causes infection, and you can hurt the kidneys by refluxing back up into the kidneys. So there's ways you can help with that. Some is a Valsalva maneuver, but if you can imagine, they already have low blood pressure and their pulse is kind of low, so we worry about that. Another one is a Credé maneuver, where you just kind of push on the bladder itself, and sometimes that can stimulate voiding. Another, just like with the upper motor neurons and that spastic bladder, catheterization and every 2-hour toileting may help. All right, so let's look at some little more specific for both of those. So I'm not going to ask you specific questions about what is upper motor, what is lower motor. Let's consider them both neurogenic bladder. So whether you have spastic or flaccid, it's called neurogenic. So let's look at some of the interventions to do for both. We want intake of 1,800, 2,000 milliliters of fluid per day. One of the best things that is used is clean intermittent catheterization. It's called CIC, and that is better than an indwelling Foley. As you know, with Foleys, really increased chance of sepsis and infection. But when people do their own clean intermittent catheterization, they've got their own bacteria, they're doing it in their own home. It's not sterile, but it is it's an effective way to keep infection down and for them to effectively relieve their bladders. And with that clean intermittent catheterization, you can see on the right, you want them to have, when they catheterize themselves, more than 150 but less than 500. So ideally you want about 80 milliliters retained. Now suppose if you're getting 600 milliliters out, then you may have to cath them more often. So more than 500, cath them more often. Let's see, drugs wise that may help. Oxybutynin is an antispasmodic, so that may help that spastic bladder. And then baclofen, that can help relax the pelvic floor for some of that spasticity. Now this is common sense here. You're going to perform bladder care prior to bowel care. So in other words, when you're cleaning, you want to do bladder care before you do bowel wise or your bowel prep. Eating yogurt decreases E. coli, Cranberry juice does decrease some bacterial growth. So those are some simple things that may decrease infections. There are some things that they can do surgical-wise to help: electrical stimulation. I'll talk about a urinary diversion, and then they can actually do a surgery to make the bladder larger. But ideally, for quality of life, the clean intermittent cath is what's most recommended for most people. Okay, so complications that we see with spinal cord injuries. If you can imagine that they can't feel the dysuria. So most of us, when we have a urinary tract infection, a UTI, we feel some dysuria. They don't. They don't know whether they have urgency because we're cathing them, and they can't feel back pain. So it's up to caregivers and for them to be real astute in what the urine looks like. For frequent UTIs, they may use pulse antibiotics, which would mean just kind of high doses for short periods of time. With in and out caths, we have to be careful of urethral trauma. You may see some hematuria of that. I know with urinary stasis, we can have things like kidney stones or that urolithiasis. We have increased chances of infection. So you can see that great urine sample there at the bottom right. This is a type of surgery that can help people with spinal cord injuries, especially women, have much easier to cath themselves. It's called Mitrofanoff surgery. They take the appendix and they use it kind of as a fistula, and they take it and make a little passageway from like the umbilicus right into the bladder, so they can easily pass like a small catheter right in through their umbilicus, right into their bladder to cath themselves. So again, this is another way of that clean intermittent catheterization that you can do this at work. You can be able to do it much easier than trying to cath yourself through your urethra. All right, let's next part. Let's look at bowel elimination. So again, we have spastic and we have flaccid. So upper motor neurons, that reflex arc is intact, and the same thing with like urination. At any point, they can defecate without warning. Any kind of stool in the colon can cause them to defecate, and this is one of the most difficult things for people with spinal cord is bowel and bladder success. With this, many times they can use a lubricated glove, a little bit of digital stimulation, and that can stimulate stool. The other thing you can use is suppositories. This Biscotal, that actually stimulates peristalsis. So 30 minutes after a meal, use that gloved stimulation, use that suppository, and you can stimulate a bowel movement. And if you do this every day, same time, you can train your bowel so they won't have accidents. With a flaccid bowel, it's a little another problem in that there's no reflex arc there. The stool just kind of stays in the colon. And if it really gets full, then you're defecating small amounts, but really you're quite constipated. So for them, many times it's manual disimpaction. All right. So let's not worry about upper motor or lower motor. Let's just say that it is a neurogenic bowel, and some of the things that that can be done. Bowel training, we want high fiber and high fluid, which is important. We can use a stool softener such as Ducosate, and that helps the stool pass more easily. It increases the water in the gut. talked about suppositories, that biscotal, that stimulates the peristalsis to help with expulsion of stool. Digital rectal stimulation relaxes that external sphincter, and we'll go over enemas in a minute. You think about how difficult this may be when you have impaired mobility and you have impaired hand dexterity. So again, major physical and psychological problem for spinal cord injuries. All right. With those people with the lower motor neuron that have loss of stool propulsion and the retention of stools, they may do something called a MACE, which is a Malone antegrade continence enema, and they actually use surgically wise, they put a stoma right into the colon. You use like an enema with 1,300 milliliters. You can do this once a day. It takes 45 to 50 minutes. They run the enema in, it dwells, and that just kind of cleans out the colon. They can do it once a day, and it makes them much more continent. Alright, so we have covered elimination, urinary and bowel. So our next topic is sexual dysfunction. So let's look at for men and for women. For men, reflex erection is very possible, and for most men, it can be either reflex or with some stimulation. They can maintain an erection, and they can also ejaculate. So the possibility of fathering children is very real. There's at times that the quality of the sperm or the amount may not be what it was pre-injury, but overall reproduction there is very possible. I have a link there, I think that's quite good, that talks about men and women, and then there's a longer link that a link to a longer panel discussion that's listed with the links at the beginning of the PowerPoint. With women, less clear effects, sometimes unable to reach orgasm, that may be a problem. Usually they remain fertile. There are times when ovulation may stop, but usually they remain fertile, so having children is definitely a possibility. Fortunately, there's complications with that, including urinary tract infections that may happen. The autonomic dysreflexia is a real problem here, but there are ways and specific OBGYNs that deal with this, so there is professional specialty there, and their uterine contractions are not felt. So that's kind of a very brief summary of sexual dysfunction for men and women. All right. I'd like you to kind of take a minute, if you would, and take a look at some of these quotes from people with spinal cord issues. While you're doing that, think about Elizabeth Kubler-Ross's theories of acceptance, whether they are in the anger, the denial, the bargaining, or the acceptance phase when you read some of these quotes. Alright, lastly, I'm not going to read these, but you can imagine that the individual, all the changes that they've gone through, and you think who primarily has been injured with spinal cord injuries. There are young men ages 16 to 30 and developmentally where they may be in life and how much that has affected them. And then the role of the nurse over here on the right hand side, what we can do to help their transition into some acceptance, help them with independent decision making, discussion of all aspects of care, including sexuality. You want to increase their independence, include the family members, and many times the goal is more towards adjustment than it really is to acceptance for them. All right. A very quick look at our drugs. As I mentioned, your methylprednisolone, steroid-wise, I still see that in some books, some questions, but really that fell out of favor back in 2013. So large doses of methylprednisolone for spinal cord injuries is not part of best practice at this point. People do have issues with hypertension, so initially we may use that plasma expanders like dextran for hypertension, norepinephrine, bradycardia, atropine. We went over the muscle relaxants and antispasmodics, tizantine, baclofen, diazepam. Antidepressants may be a part of care here. Our proton pump inhibitors, because of increased acid, chances of ulcers and GI bleeds. We went over anticoagulants. We're looking also at pain, NSAIDs, really try to decrease narcotics. Gabapentin may be used for pain and for neuropathic pain. Sometimes people still have pain in their extremities, although they're paralyzed there. Then, of course, for neurogenic bladder, oxybutyn. All right, our last big topic here that we'll go over is autonomic dysreflexia. And for you to have autonomic dysreflexia, spinal shock must resolve. Right? So, and again, this happens with people that are usually above T6, and it's an overactivity of the autonomic nervous system. So again, it happens when the upper motor neurons aren't talking to the lower motor neurons. And the characteristic piece here is that there's an irritating stimulus below the level of the injury. So something's happened below the level of the injury that's really stimulating that autonomic nervous system. It is serious if it's not taken care of. This severe hypertension can lead to stroke, MI, and death. And I have a pretty good link here that I think it's Nurse RN that gives a really good overview of this. All right, so what can cause this? Characteristically, it is an overfull bladder or overfull bowel. So bowel and bladder things are usually the culprits. So for prevention, you really want to cath and use good bowel protocols to prevent this. Pressure sores can do it, ingrown toenails, tight-fitting clothing such as belts, shoes, tight socks, even the way men are sitting, if they're sitting on the scrotum, maybe pinching, that can cause it. Any kind of burns, bone fractures, and actually sex. So, what do we see here? Above the injury, we've got a flushed face, sweating, severe headache. The sympathetic nervous system is trying to bring down the pulse, so you've got a low pulse. They've got a stuffy nose, they're short of breath. So here we go, it's trying to relieve the blood pressure from above. And below, we've got vasoconstriction, which means they're pale, they've got cold skin, but they're unable to sweat. So we got vasoconstriction below, we have vasodilation up above, but the vasoconstriction is taking over. So we really have to worry about blood pressure. Okay, with autonomic dysreflexia, you now know some of the symptoms, so let's look at the treatment. I'm going to say they have a headache, some stuffiness, severe headache, so go ahead and take their blood pressure. And consider that their normal is usually about 90 to 110 systolic, so if it is elevated beyond that, consider that it may be autonomic dysreflexia. So we want to really decrease that blood pressure. So elevating the head of the bed and lowering their legs will help, because we know they have trouble with orthostatic hypotension. But once you do that, you have to a little detective work to find out what's causing it. It could be clothing. It could be a tight belt. When was the last time they were cathed? Did they have any kind of fecal impaction? Do they have any skin issues? What do their feet look like? And it is something that you can fix, then that blood pressure will go down. If it's something that can't be fixed, say it's an ingrown toenail or some kind of skin injury, then we need to go a little bit further. And the nitroglycerin, which may buy you a bit of time, if they've used sildenafil, you can use things like captopril or nifedipine. Most people with spinal cord injuries will have these drugs. They'll have them as PRNs, especially it seems like people who have autonomic dysreflexia, they don't just have it once, but it tends to be a continuous problem. So they'll probably have these drugs on hand. So if you can relieve the cause, then their blood pressure should turn back to normal, and you want to continue monitoring their blood pressure. If it can't find the stimulus, or you find that the stimulus is not something that you can fix, such as that ingrown toenail, so you need to call 911, you need EMS, get them to the hospital. They use things, vasodilators such as Hyperstat or hydralazine IV to bring that blood pressure down. So this is real specific to spinal cord injuries. It happens when the upper motor neurons, not talking with the lower motor neurons, the very much hypertension that's going on below the level of injury in the upper part of the spinal cord is not able to communicate with the lower part to say, hey, this isn't that bad, go ahead and bring down that blood pressure. So the next slide might help a little bit more with the specifics. I'm going to leave you with a few updates. There's something called a phrenic nerve pacer. You can see pictures there on the right where there's an implanted device which stimulates that phrenic nerve and causes the diaphragm to contract, which means that they inhale. So you can see that great picture of that toddler there using that type of device. So that prevents them from being on a ventilator. There's some stem cells, the idea that stem cells may limit the inflammation in a spinal cord injury and may promote some cell growth there. In a few there's been mixed results in some within the human trials. You may have seen this about functional electrical stimulation, where they use small electrical pulses to those paralyzed muscles, and that helps restore, improve some of their function. You've kind of maybe seen this to help people walk. Then there's electrical stimulation of the spine, again trying to reestablish some of those nerve pathways. And then the idea of neural tissue transplants. And the problem with this is that when nerves are damaged, they form like a glial scar. So it's real difficult to transplant this or reconnect any of the nerves. So, all right, thank you. I hope you will contact me with any questions about this. I know it went fairly quickly, but please email me or see me on Teams and to answer any questions. Thank you.